Well, hello there. I am ready to talk to you about newborn and infants in pediatrics, and this comes from chapter 8 of our F.A. Davis textbook. I did mention previously that a lot of the newborn content I'm not going to go in depth on since that information is actually being covered in your OB Women's Health course, but there is still some of the information that's relevant that we're going to touch on within this PowerPoint. The objectives we're going to be addressing with this content are to do with growth and development and what you should understand about the newborn and infancy phase. Also, that physical assessment is going to differ depending on what you're taking care of, what age child, the demeanor of the child, the milestones they've already achieved, and kind of what they're working towards. We know that health promotion is essential for the child and the child's family, and that's going to be influenced by a lot of things in their environment and in that family's structure. That our procedures are going to be determined also based on the child's age and developmental progression, that there are different threats or things that are more concerning or severe depending on how old the child is, that we know that their setting is very important, and so a child who's hospitalized or who has chronic care needs is going to probably have a different progression through the normal development than a child that doesn't require hospitalization or doesn't have any chronic health conditions. And that there are important safety measures that we need to be aware of when caring for the child, especially within the home. Okay, so a couple things to make sure you're familiar with are some terminology. What is considered a newborn versus an infant? So a newborn is a child within that first month of life, 28 days to be specific, but we usually just refer to it as a child within the first month. A child that's a month old and older on through a year would be considered an infant. So once they have outgrown those first 4 weeks of life, then we transition our verbiage to infant. And then a preterm infant is any child that's born before a certain gestational age. In this case, your book refers to the 37th week of pregnancy. A child that's born before the end of the 37th week of pregnancy is a premature infant. Now, this is something that does differ in literature and in practice. You may hear certain other definitions of what constitutes prematurity, but what we're going to test on and what we're expecting you to know is what matches our resource for this class, which is what's the F.A. Davis book. Okay, the next few slides are going to cover different systems of the body and specifically what is important to point out for this developmental phase, newborn and infant, within that body system. And then some of this is just going to be surface level because we're going to talk about it more when we get to that system of the body later. And in that situation, we're going to be discussing all the different developmental phases and how it pertains to that bodily system. So for the respiratory system, some things to remember is that infants are by nature nasal breathers. That means that, they primarily breathe through their nose. It is important that we ensure patency for that reason, because for us, if we have any nasal obstruction or, severe congestion, we know we can just opt to breathing orally. But babies, that's not their natural inclination. Babies use their mouths primarily for sucking. So they're either using it to take a bottle or to feed from the breast of the mom. They may be taking a pacifier, even sucking on their fingers, but they're not, just naturally using their mouth for breathing purposes. Another thing that's different about babies is that their breathing patterns tend to be irregular, more sporadic, and shallow breaths. So it's not uncommon to have a baby, even one that's laying still, sleeping even, to have periods of apnea or, pauses in their breathing, or to have breath rate that is pretty rapid and then slows down suddenly and then changes again. If we're trying to identify indication of difficulty breathing, the things we're going to most often see are nasal flaring, which is that outward movement of the nostrils when the child is breathing in. Grunting. Grunting is a sound that you hear when the child's exhaling or on expiration, and it has to do with the partial closing of the glottis structure. And then retractions, and we're pretty familiar with retractions already. That's that accessory muscle use in the diaphragm. It could happen in the intercostal spaces. It's associated with this increased negative pressure is causing the backward movement of the rib cage, basically. And you can have retractions of differing severity, suprasternal, supraclavicular, intercostal, subcostal, substernal. They're all different places on the body, and they all have indication of different levels of severity of distress, but that we'll cover more of when we get to that content in the respiratory chapter. And another thing is to remember that acrocyanosis, or that bluish discoloration of the hands and feet, that's normal in the first 2 days of life. So when you have a baby in that newborn period, specifically the first 2 days, and you're noticing that they kind of have the blue or purple extremities or fingers and toes, it doesn't necessarily mean there's anything to be worried about. That's pretty typical of your newborn baby. Clinical judgment, some things to keep in mind since we're talking about, making sure that the child's or the infant's nose is patent. We also want to remember that there's suctioning that differs from the suctioning you're used to in the adult patient. You think of suctioning, you're usually thinking of like the long plastic yonker that's being used to go in and, eliminate secretions in the patient's mouth. Well, in this case, we might be talking more about like bulb syringe suctioning, which is, this syringe that you compress, and that helps to create that suction mechanism so that when you release it, wherever you've placed it, it's hopefully, grasping whatever secretions are in its path. So usually used in the mouth, sometimes also in the nose, to get mucus and snot and things, to get that clear for the tract for the patient's breathing. Need to be mindful of what are considered normal vital signs for a newborn and an infant. They differ drastically from your adults. Like if you haven't already had the experience of listening to and hearing a patient have a heart rate of 160 or a breath rate of 60 breaths per minute, it's gonna shock you when it happens the first time. But that's reality for this age group, is they have a pulse that's anywhere from 120 to 160 beats per minute at rest. They have respiratory rate of 30 to 60 breaths per minute. And then remember too that, we discussed it can be irregular. It also can be a more noticeable diaphragm breathing or movement of the abdomen when they're breathing. And it doesn't have to mean retractions or distress. Just because of their size and premature or young maturity, it's pretty standard for those things to be visible with their respiratory patterns. When a child's asleep, we would expect those vitals to be slower. When they're awake, especially if they're crying, we would expect there to be some increase to those as well. When you're taking the circulatory assessment for the child, it's important to count for a full minute. That's for getting the patient's pulse, but that's also for the patient's respiratory rate, because we want to be able to account for some of those irregularities that might occur within that 60 seconds. And if we're not listening for at least 60 seconds, we're probably not going to be able to pick up on those. When the child gets older, the trends you can anticipate are that their heart rate's going to slow down and their blood pressure is going to increase. Thermoregulation or thermoregulatory system. We know that newborns do not shiver. We know that the brown fat utilization process is that fat is broken down into glycerol and fatty acids that's used to produce heat for the body. So that's why it's so important that children or infants, when they're first born, experience kangaroo care, which is the skin-to-skin contact with the caregivers. And there's some information about that specifically in your textbook on page 127. It's under a critical component, and so if that's not a familiar term to you, kangaroo care or skin-to-skin care with the baby, you would definitely benefit from reviewing the critical component on page 127. In terms of the metabolic system, an important term to be familiar with is phenylketonuria. We tend to abbreviate that PKU. Basically, the patient that has phenylketonuria has a deficiency of phenylalanine, which is an enzyme in the body. And this is actually one of the most common metabolic errors that happens in babies. So you'll learn more about that, I'm sure, in your women's health content as well. Newborn screening, we know that there are certain screenings that are done universally, which means that they're done on every child. Sometimes screenings are done via risk assessment, which means we look for certain kids that have an increased risk of having some kind of potential condition or diagnosis, and so we screen them. And then we have what they call selective screenings, which is usually like a certain age bracket or maybe a certain ethnicity, population, or something of that nature. Well, newborn screening, which is used to screen for metabolic disorders at birth, that's an example of a universal screening. That's it on every child. Each state's going to have its own way of regulating that, but the expectation is that it's performed within the first 1 to 2 days of life, and then if there's anything abnormal about it or anything concerning, it may be addressed at the follow-up wellness visit with the child's pediatrician. Sickle cell disease is something that the metabolic screening that's done universally is meant to detect. Remember that someone can have sickle cell disease or they can be a carrier of the trait. And so that information is known based on the results of that metabolic screening. Sickle cell disease is associated with red blood cells that have become misshaped or sickled, and it interferes with the blood flow. It doesn't allow for the expansion of the cell, and it doesn't allow for the easy flow of blood, which we know can result in complications for the individual experiencing that condition. There's no cure for sickle cell disease, but again, some people aren't actually going to manifest the disease itself. They're just going to be carriers of the trait. Cystic fibrosis is something else that the metabolic screening is meant to detect. And with cystic fibrosis, that is where the body produces an excess amount of mucus, and it tends to cause problems for the lungs and the digestive tract. It interferes with normal functioning and breathing, and so this person is generally going to require a variety of medications, a pretty involved medication regimen for life. They're going to typically stay sick. They have what we would consider a weakened immune system, and they need care for this on a lifelong basis. In reference to the hepatic system, specifically want to mention hyperbilirubinemia. This is an excess of bilirubin in the blood. It is associated with a patient having slow bilirubin clearance, so that means that they're not able to excrete it. It results in a higher hematocrit reading, and it's associated with a shorter lifespan for the red blood cells. Typically, the problem at hand is the liver. It's immature, and so this conjugation process is also going to be immature. What we would expect for normal values is less than 5.2 in that first 24 hours of life. So somebody that has something exceeding 5.2 may be in what we'd consider hyperbilirubinemia state. Kernicterus is a life-threatening buildup of bilirubin that can cause nerve and neuro damage to the patient associated with the brain and the spinal cord. So that would be a complication of hyperbilirubinemia that can happen if it's not addressed. And the way in which it's primarily addressed is Billy Light. The patient is placed under this medical light to help with the excretion of bilirubin in the body. The way that it will manifest for the infant is that they will have a jaundice, discoloration of the skin, usually the sclera, also maybe the oral mucous membranes. We'll see it primarily on the face. It tends to involve the nose, but it can spread down the trunk, even to the extremities as well. And you'll be able to tell because when a pressure is applied with the fingertip, it doesn't blanch. It doesn't change color. It stays this jaundice appearance. Coombs test is a way in which can get a more definitive identification of the patient's red blood cell breakdown if it's abnormal. It's also how we determine a mother who's Rh negative from an Rh positive baby. They're going to experience a higher risk for hemolytic disease. Phototherapy is the correct term for the treatment for the patient with hyperbilirubinemia. The child's placed under a blue-green fluorescent light that is used to help convert the bilirubin in their skin to a form that can be excreted through the baby's feces or urine. They do want to make sure that the baby's eyes are protected, so they're covered. This helps to prevent cataracts from forming. And aside from having a diaper on the baby and their eyes covered, the skin is otherwise fully exposed during phototherapy sessions. The child's temperature needs to be monitored closely, and if the child experiences high-pitched crying, arching of the body, these kinds of unexpected manifestations, it could be associated with acute bilirubin encephalopathy, which of course is an emergency and would require further evaluation and treatment if that were to be the case. Okay, the gastrointestinal system. Biggest thing I want to make you aware of is how tiny the baby's stomach is at infancy or newborn phase. So this is, from your textbook, a capacity of 30 to 60 mils at birth. 30 to 60 is by definition 1 to 2 ounces. I mean, that is very small if you think about it, compared to what, as adults we're used to consuming in any, one sitting. So it's very important that you keep in mind that, how the baby is fed, what kind of, gastric returns you get if you're ever evaluating a baby's, NG residual or, PEG feeding residual. That's probably significant because they have much smaller stomachs to start with. Meconium is the term for the first stool that a newborn excretes. It is usually very noticeable in that it's a black color, it's a sticky, tarry appearance, and it's normally the way the stool looks or presents in that first 1 to 2 days when the baby's born. Babies should be being fed at least every 4 hours. Oftentimes they're eating more frequent than that, especially if they're a baby that's breastfed, because that, feed is digested and metabolized so much more quickly. But different babies can go different lengths of time. It's important to consider, emptying time, and that some babies need the more frequent feeds if their metabolisms are pretty rapid. There is going to be some differentiation between a child that's fed breast milk and a child that's bottle fed formula. So babies that have been given breast milk, their stools are going to generally be a golden color. They're less formed, looser, versus a child that's got formula. They're typically going to have a drier and more pale yellow to green, even, black or brown stools when they poop. Breastfed babies are going to eat more frequently because the breast milk is more easily digested, and so they empty it faster, they get hungry again sooner. Breastfed babies also tend to have more stools, and usually they accompany a feeding. So it's very common for a baby who's breastfed to have a bowel movement while they're eating or nursing. Bottle-fed baby could go a lot longer between bowel movements. May even experience what we'd consider constipation. It's not abnormal for a baby to go 1 or 2 days without pooping if they're bottle fed versus the baby that's breastfed. In terms of genitourinary, the things to remember is that the kidneys cannot concentrate or dilute urine in response to changes in their fluid status. So that is a key element to the immaturity of the baby's GU system. And that makes that baby at great risk for dehydration, just like they are at great risk for fluid overload. That's why it's so important that we monitor the child to determine any indicators of hydration status being below the expected, but also that we prevent any overload or volume, exceeding the norm. We talk about, water intolerance, like babies don't just drink water. Their water is part of their formula. A baby that's breastfed does not also receive water. They just get the breast milk, because if you overload them with fluid, you can cause some pretty drastic changes in their intravascular status. We also know that babies are more prone to extracellular fluid loss. That's why maintaining their temperature is important, making sure that, their environment is safe. And as far as indicating hydration, the typical, some literature says 8 to 10, your book says 6 to 10, so that's what we're going to go with, but 6 to 10 wet diapers a day is indicative of a adequately hydrated baby. If they're having fewer than that, then we might be concerned that they're not receiving enough, nutrition, or that they have experienced dehydration in some capacity. When talking about, effective nursing care, one thing that your book spends a little bit of time describing is sucrose solution. This is basically like sugar water, is what you might have heard it called before. It's a pain reliever, a natural approach to pain relief. So there are these endogenous opioid pathways in the brain. And when you do things like this sugar water mixture, the idea is it's trying to improve or increase these natural pain relievers for the child, for the baby. The sucrose solution actually does require physician's order. It's used in minor procedures like circumcision would be one example. You document it as though it's a medication that you've administered. And by the baby having the sucrose and the non-nutritive sucking, it's activating these endogenous opioid pathways. It's used for calming and for pain relieving purposes in infants. When discussing the integumentary system, some important words you might recognize are nevi and stork bites and Mongolian spots. These are all different variations of birthmarks, and they tend to be associated with certain ethnicities or, race, different cultural backgrounds. So Mongolian spots are specifically more common in African Americans, Hispanics, and those of Mediterranean descent. They tend to look kind of like a bruise. They're like grayish, blue or black almost, usually in the sacral region, so, above or on the buttocks area. And again, we see them most often in these certain ethnic cultures. Whereas, nevi is like the brown birthmark that forms. Stork bites tend to be on the back of the head, almost where the head and neck meet, and they tend to be like a light pink or red color. And they're kind of a blemish to the skin in that location. When talking about the baby's umbilical cord, things to remember is that it's going to dry out. It's going to become black and hard, and that's expected. It should then fall off on its own within about 2 weeks. And the main thing to encourage caregivers and remember as nurses in the meantime is that we're keeping that diaper just below the cord so that we don't have the friction and movement of the diaper area on the cord. We want to fold the diaper down to where it is not obstructing that cord area. Cradle cap is something you may hear referenced. It's usually referring to the head of a baby, and it's associated with essentially dry scalp. They get this scaly, crusty area on the scalp that tends to flake off and peel. And it's associated with the buildup of oils and dead skin. So one way that it can be managed is by daily washing and then drying the head. Sometimes you'll see, parents put some baby oil on the baby's hair to help try to moisturize the skin. Well, in reality, because it's a buildup of oils and dead skin that creates this cradle cap formation, the baby oil typically ends up, making it worse rather than better. So when we're talking about the infant's immune system, it is not going to be considered fully developed until the child is 6 months old. Beginning at about ages 2 to 3 months, the body starts to produce its own antibodies, but it's still going to be an immature immune system for some time. We know that babies do receive some maternal immunity from the mother because of the ability for some immunity to pass, like IgG for one. It's the only one actually that can cross the placental barrier during pregnancy. But even with these maternal immunity or antibodies that we get, it's just temporary passive immunity until the body is able to develop its own immunity. The term active humoral immunity, that is when the body actually acquires the immunity from having had the vaccination or having been exposed to the virus or disease in question. So active humoral immunity is acquired from vaccination or the body's natural production of antibodies because of antigen exposure. Another element that tends to surface in this first year of life is food allergies. There was an opinion that we should delay exposure to foods that are likely to be allergies for babies because the longer it is before they encounter them, the less chance of them having an allergic reaction. And now your book even says that there's no evidence to support that. There's no evidence that says that delaying the introduction of these foods beyond 6 months old or older is going to have any effect on whether the patient's going to develop allergies. In fact, it says the opposite, that research recently is actually encouraging introduction early to these different foods, like around 4 months old, because doing so may actually form protection and prevent an allergy to those things. Infants are at increased risk for infection because of their immature immune responses, the lack of antibodies they received maternally, the stress that depletes the immune system, and because of breaks in the skin that are caused by invasive procedures. So this is just, touching on the reasons why it's so common for infection to ensue in the babies. Okay. In referencing the child's head and neck, some terms you may not have heard before are fontanelles or soft spots. This is really important. This is basically what happens when the skull has not completely formed. There's these gaps, and they, occur in different places and close at different points in life. So the posterior is actually like the back of the head, usually where the hairline meets. And that one closes the earliest. Usually, your book says 4 to 6 weeks. It's usually even sooner than that, like 3 to 4 weeks of life. Whereas the anterior, that's the one on top. So, kind of, midline on the top of the head. And that one usually takes from 12 to 18 months for it to close. So this anterior fontanelle is something that can be utilized as a indication for things in the body as far as like hydration, for example. If a child were dehydrated, we would expect that fontanelle would possibly be sunken in, it'd be depressed. Whereas if a fontanelle is bulging or enlarged, it could be associated with increased intracranial pressure. Like something happening in the brain, like a brain bleed or increased ICP. So what you would expect it to be in its normal state is just soft and flat. Like you can feel it, and it doesn't actually go down, it doesn't bulge upward, it's just soft and flat. In reference to the baby's eyes and ears, one unique fact is that they don't make tears until they're about 2 months old. So their crying is going to be tearless in the initial stages. Also, babies should be startling to noises that they hear. They should be moving their eyes to follow sounds that they hear, just like they should things that they see. And that is why, we're going to learn when we get to more of the eyes, ears, nose, throat content, that hearing is the one sense that's intact since birth. They do hearing screens on all babies as soon as they're born in the hospital. It's another example of a universal screening that's done because babies' hearing should be already matured or developed from the time that they are born. We mentioned previously in the respiratory content that they are obligatory nose breathers, so they primarily breathe through their nose. In referencing their mouth, besides using it for sucking purposes and nutritive purposes like feeding, also we want to remember that they are going to develop teeth, and that usually happens around 6 months of life. They start to have teeth erupt. And when they're teething, there's going to be some pretty noticeable indicators. The baby's going to be drooling. They're usually more restless and more fussy. They tend to be sucking or chewing on their hands or any object they can get their hands on. And then they also may develop a rash around their mouth that is also associated with the saliva accumulation in the drooling that they're experiencing. We do want to recommend to the baby's caregivers that they be brought to the dentist. Once that first tooth erupts, that's a good time to suggest that they be seen, and then they should be seen on a Q6 month basis. Sometimes we have some abnormalities in terms of babies' mouths, and one way is that they can have a cleft lip or even a cleft palate, which is where there's like a change in the structure of it. These tend to be common in babies, and they are most often associated with feeding difficulties because of the baby's inability to grasp or suck adequately. In general, cleft lip is the more popular, but it's also more popular in boys, whereas cleft palate tends to be more often seen in girls. I do have a note on the slide to tell you that folic acid intake is very crucial in pregnancy, and it tends to be associated with increase in cleft lip and cleft palate incidence if its intake is deficient. Also, babies that have been exposed to alcohol or smoking in the womb have been more inclined to have cleft lip or palate deformities. Also, certain medications can increase the risk of cleft lip or cleft palate occurring. Meds like Accutane or Dilantin during pregnancy are just some examples. We see feeding problems as the consequence most often because of their inability to create a seal on the bottle or on the breast, depending on how they're trying to eat. This also puts them at greater risk for aspiration. And sometimes it's going to result in a need for adaptive feeding methods for the baby. These babies that have cleft lip and cleft palate also tend to have more frequent ear infections. They tend to have more issues with speech delay, and they tend to have more dental problems like cavity formation. We want to make sure that any child that has a cleft lip or cleft palate is still receiving adequate fluid intake and a balanced nutrition. And usually they can do the necessary surgeries to correct this in the first few months of life. Sometimes they will wait till the baby's a little bit older. Sometimes it requires more than one surgery to complete it, but it usually can be done starting at about 2 or 3 months of age. When we're talking about cleft lip and cleft palate and that surgery that's needed to correct it, it's important to pay attention to what are some of the post-op care instructions with these two repairs. So after a baby has undergone a cleft lip or palate repair, they're going to be NPO, probably for a little while. They're going to need to be on a side position or on their back. We don't want them on their stomach, and we don't want them on the same side that the repair was on, because we don't want them rubbing that suture line and the friction of that movement to disturb the suture. We want to obviously pay attention to and monitor their respiratory status, because that's something that could potentially suffer. It may be that the patient requires restraints for some time, something like soft elbow splints, so that they can, keep from messing with the area where the procedure occurred. We want the child to avoid straws, use of pacifiers, tinsels, any oral suctioning, and breastfeeding for a length of time to allow the suture line to heal. The baby should be fed upright and burped often, with the flow provided away from the defect. So we're not, trying to interfere with the site of the surgical repair that took place. Each time the baby feeds, the mouth needs to be rinsed and the suture line needs to be cleaned to make sure that no residue is being left behind that has a chance to, have any bacterial growth or anything else occur. And sometimes there's topical ointment needed, for antibiotic or infection purposes. So if that's ordered, we want to make sure that that's applied appropriately as well. Okay, in referencing the neurological system, want to focus on the reflexes and how they differ. So there's two categories: primitive or innate reflexes versus postural or protective reflexes. So innate by definition means like at birth. Primitive, obviously in the beginning. These examples are listed in your book in Table 8.7 on page 145. These would be things like the Moro, the sucking reflex, the Palmer, the grasp, okay, all those different ones. The protective or postural reflexes, those are not since birth. Those are going to develop over time and usually start to develop as some of these primitive reflexes are resolving or going away. The two that I want to bring attention to, examples of protective or postural reflexes, are called parachute and riding. Parachute, is going to be pretty easy to understand. It's basically when the baby puts their arms out and tries to brace themselves or catch their self when they're falling. They should do this naturally. If you pick up the baby and pretend like you're facing them towards the ground, like they're going to be diving down, they should want to put their hands out to protect themselves in that position. And that's, again, not something that's the case from the beginning of life. That's something that they develop. The riding reflex, it has to do with their ability to balance themselves out. So basically the riding reflex is what enables a baby to lift their head while they're on their tummy. So if you lay them on their tummy, lay them prone, and they're able to pull their head up, that's one example of the riding reflex. If you hold the infant vertically and slowly start to tilt them to one side, they're going to try to bring themselves back upright. So that riding reflex is their efforts to correct what you're doing to their posture or their balance. All right, some other parameters to be familiar with in terms of the physical development of the child. Weight, you want to know what it means when you read acronyms like SGA, LGA, AGA. Small for gestational age, large for gestational age, average gestational age. So, the average infant weight, according to your book, is 7.5 pounds, 7 pounds, 8 ounces. Now, we know there's a lot of factors that play into that. The age the baby's born, so how gestationally, early they are, the genetics of the family, the mom's, diet and health during the pregnancy. So there's a lot of different factors, but this is just an example of, an approximate average weight for a baby. Average length at birth would be 20 inches, and we talked about growth charts briefly the other day, that they're used to, identify trends in growth patterns and notice if a child all of a sudden falls off of the growth chart or has some, significant peak or dip in their pattern. The head circumference is something else that we monitor routinely. And usually the head circumference is equivalent to the circumference of the chest. But we want to be monitoring it in those first few years of life, especially while that fontanelle is open, because it can be indicative of any changes in the baby's intracranial pressure, just like it can be indicative of changes in their hydration status. It has a lot of benefits. Now, that's more so the fontanelles that we're going to see that differentiation. But if you've got a baby with a brain bleed or increased ICP, over time, that head circumference is going to enlarge if those fontanelles are still open. I think I said AGA for average gestational age, but really it's appropriate gestational age is the correct terminology. And just to point out, one possible cause for SGA or small gestational age is intrauterine growth restriction, which is pretty common in pregnancies. It's when the baby basically doesn't have room to grow anymore within the uterus, and so sometimes that baby has to be born early, or that baby's just small because they ran out of space for growth. Okay, the next few slides are going to cover different milestones and what's expected for them. I'm actually not going to sit here and read them all to you because you can do that. You can look through these. But we kind of did an activity in class where we familiarized ourselves with some of the significant milestones that we would expect in terms of gross motor versus fine motor at different ages in the first few years of life. This is basically that, but with a little bit more detail, a little bit more in depth. So this touches on, growth changes in terms of weight and height and head circumference, the development of certain reflexes, some language development like the social smiling, the blowing bubbles, being able to laugh. Those are just some examples of things that we would expect in those first couple of months. We know that the baby's birth weight's going to change. In our notes that we have from class from chapter 7, talks about it happening in the first 4 to 6 months. The birth weight's going to double. We expect their baby to be able to roll over from their belly to their back. They should start reaching and grasping things, even, if it's just the parent's finger or parent's hair, okay? They should start doing more with their own hands and feet. They should be able to move objects to the mouth, so they should be able to, hold something like the pacifier and put it in their mouth, or hold the bottle and put it in their mouth. We see some of those primitive reflexes beginning to disappear at this age. We see the surfacing of their teeth, the eruption of teeth or teething. They should be sitting with support or assistance. Sometimes they're starting to become anxious when separated from their primary caregivers, and they start making some noises like babbling sounds that are repetitive in nature. At 6 to 9 months, the baby should be able to roll both directions, from back to belly and from belly to back. They should be able to sit, without support, so they don't even need help anymore. They are able to pass objects between their hands. They can point to things, and they're starting to pick up items or objects in front of them, like Cheerios or, their pacifier. They may start to develop some taste preferences, so it may make that, where you notice them not wanting certain vegetables that you offer them, and they're preferring or favoring other things like the fruits that you want to give them. Have some stranger anxiety, so before it was separation from caregiver, now it's somebody I don't know approaching me, wanting to hold me or wanting to interact with me makes me anxious. We still see that babbling, but now it's paired with some repetition of mama and dada. The child should be getting to where they're wanting to pull up and stand, maybe crawling from one place to another. And they're going to have a increased visual ability. They can distinguish colors, and they can see from a farther distance now. At 9 to 12 months, their birth weight is going to triple. So by the time they're a year old, we expect them to be 3 times what they were when they were born. Their length also increases by approximately 50%. They are walking along furniture now, if not taking steps and moving independently. They should be drinking from a cup, and we should be getting ready to transition them from, formula or breast milk to whole milk. They're probably standing by themselves now. They're maybe eating or feeding themselves with a spoon, or maybe just finger foods at this point. We see the stranger and separation anxieties at the greatest height now. They're very prominent. And we notice the child starting to say a couple of words repetitively besides just, identifying dada and mama. With their sensory development, gave a list of, what you can anticipate is the least mature versus the most, or just kind of, average. So hearing is the only one that's fully developed at birth, and that's why we do a newborn screening on all children. Vision would be the least developed. In those early first few months of life, the baby is only able to see black and white. A lot of times they're not even seeing bright colors right away. That's one of those that develops. And they don't see things at any great distance. Everything they can see is right there in front of their face. The other senses like smell, taste, and touch, those are all adequately developed at the time of birth. They should be able to identify their mother's scent, natural scent. We know that touch is important, very important for their development, and we know that if, tasting if they were going to give a preference, it would be something sweet that they would prefer. Language acquisition, put that it's partly innate, partly learned, because some language is just going to happen naturally, even if the child's never taught it. For example, I've told you before that my son Isaac was raised in a single parent home. There was no dad in the picture. So in my opinion, he should not have learned dada, because nobody said that in his company. Nobody said that in our house, because there wasn't a person filling that role. And yet, even before he learned mama, he learned dada. So some of it is just innate. It's just going to happen on its own. It doesn't depend on the environment. Okay, in this phase, this newborn period, the important milestone, according to Erickson, is the development of trust versus mistrust. And I want to note that, trust in infancy, that is necessary for how the child's going to interact with the world long term. So if they develop trust in infancy, that's going to give them or provide them with this lifelong expectation that the world is good and pleasant and that people can be trusted. It's when they're neglected and those needs, those basic care needs are not met, that they have that sense of mistrust, and there's more complications that occur in terms of their interaction with the world. We've said already that play is important. This is how infants learn about themselves and the world around them. Play should be sensory motor focused. They should be able to explore with their mouth in a safe capacity. So that's why we want to make sure anything small that they could choke on is removed from, their access, and that their exploration comes from imitation of other people. And safety is obviously very, very important. Infants develop on all levels, and they're influenced by cultural context, neurodevelopment, experiences with others, the list goes on. Their play needs to be supervised. It should involve tummy time. They should be able to hear soothing tones, see, a variety of facial expressions. They like looking at themselves in the mirror. Play can be very simple for this age group. It doesn't have to be, the fancy, expensive toys for them to be able to enjoy it. Okay, in reference to nutrition, some terms to be familiar with. One is the extrusion reflex. This is where the child is likely to reject solid foods before a certain point in life. So babies generally don't start taking in solids like cereal, which is, rice or oatmeal or baby foods, until about 6 months old. And the reason that that's generally avoided until then is because they have this extrusion reflex where they're going to force out or push away solid foods before that time frame. So once that reflex goes away, that's one good indication the baby's ready to start having that solid nutrition. It's also important that babies get an adequate amount of iron in their diet. They may require iron supplementation in other forms because the maternal stores that they had received have started depleting by now. So they may need, an increase in the fortified infant cereals, spinach, broccoli, green peas or beans, We probably won't do red meats at 6 months, but once they're on table food, so that they can ensure adequate iron intake. We also tend to discourage introduction of cow's milk until the baby is a year old. And once the baby is on cow's milk, it's important to consider that, an excess amount of milk can actually also result in iron deficiency or the need for iron supplements, because milk interferes with the absorption of iron. So if you have a whole lot of milk, you probably are going to end up, experiencing that iron deficiency anemia. Non-nutritive sucking is sucking that takes place with the fingers or the fist in the mouth. It might be with pacifiers. And so that's one way to help soothe the baby, or for the baby to learn to self-soothe. And when talking about heating milk, so this would probably be in the case of like formula, maybe formula, or even breast milk that was, frozen or refrigerated at one time. You never heat milk in the microwave, okay? You want to be careful using the microwave for anything for children, because it has, generally speaking, an unequal distribution of heat. So if you needed to thaw or heat, milk for the baby, the way you would go about doing that is you take a cup, you'd fill it with water, you'd microwave the water in that cup, and then you'd put the bottle or the jar of baby food or the bag of breast milk into the water that has been microwaved, and you let it just sit in the hot water. And that will guarantee a more equal distribution of heat, so that you don't have places in the milk that are room temp, and then next thing you know, scalding hot, they're burning their tongue or throat from it. Okay, solid foods. So we know that as the baby grows, their calorie needs increase. This first year of life, the baby's calorie needs are higher than at any other time in their development. Once the baby is 6 months old and that extrusion reflex has waned, that's when we want to start introducing solid food to the baby. It's also the time frame when their GI system is mature enough to digest the solids that they're going to be given. We want to introduce foods, one particular new food for a couple of days before we introduce something else, which gives us time to observe for any reactions like rash or abdominal cramping or vomiting, diarrhea that could be associated with the food sensitivity or food allergy. We want to use the spoon to introduce solids, not the bottle, so we don't put the baby food inside the bottle. We typically recommend beginning with the cereal, the rice or oatmeal cereal, and then transitioning to fruits and vegetables as they tolerate it. When the baby is about 8 to 9 months, they can have strained meats. Even some brands make some jars of meat that can be given to them at that age. And then for self-feeding, we want to introduce that when the baby's able to sit by themselves and can hold their neck up steady and keep food in their mouth. Babies should never be, or children in general, shouldn't be eating unattended. We always want to be mindful of the choking risk or choking hazards and be paying close attention when they're eating. One way we can try to prevent choking is to always cut their food into very tiny pieces, and then avoiding foods that are just by nature an increased risk of choking. Remember that when kids cut their first few teeth, they come in usually in the front of the mouth. Those are biting teeth. Those are not grinding, chewing teeth. So just because a child has a few teeth does not mean they're ready for a piece of steak, okay? Because they're not going to be able to break it down. They're going to try swallowing it whole, and then we've got the danger of choking. Also want to avoid honey and corn syrup in infants in that first year of life because of its increased risk of botulinum bacteria. Let's talk about sleep for a minute. So babies' sleep patterns, this is gonna vary by child, but on average, a child or a baby needs to sleep at least 8 to 9 hours during the day and at least 8 hours at night. Once the babies get to be about 3 months old, they usually can start sleeping through the night. Infants 4 to 12 months should sleep approximately 12 to 16 hours per 24 hours, and that includes their naps in that. At 3 months, their REM sleep decreases and non-REM sleep cycles begin, and that's what we consider like the quiet sleep. That's when they tend to go longer stretches without waking up. Growth spurts do tend to impact sleep patterns. So a lot of times if a baby's going through a growth spurt, they're going to sleep more frequently, or they're going to have increased sleep tendencies. And co-bedding is just something that, you have to decide as a family if that's something that you're going to participate in, but make sure that the family's aware of the risks, that it is discouraged because of the potential for suffocation for that baby. So it's not something that is generally encouraged. SUID, also known as sudden unexplained infant death, which we used to refer to as SIDS, is the leading cause of death for a child 1 month to 1 year of age, and the most often time we see it occur is between 2 and 4 months old. We see it more in males, more in the winter months of the year, and more in the Black and American Indian populations. Safe to Sleep is a campaign or a program. There's more about it on page 156 in your textbook, but it talks about all the ways in which they advocate for safe sleep. So, things like making sure that there's no linens in the bed with the child. The child's put to sleep on their back. You don't use, crib bumpers in the bed. You don't have the child use a pillow or a stuffed animal to sleep with. It's very minimal so that there's decreased likelihood of suffocation tendencies. And then BREW, which is brief, resolved, unexplained event. We used to talk about it as ALT, which was the apparent life-threatening event, but basically this is when a patient, has a very severe, unexplained, life-threatening complication or event. We tend to hear it said as a near-miss sudden infant death. Like, basically, had it gone on any longer, it probably would have been a SIDS situation. But somehow the child, was revived. They didn't end up dying, but they experienced this, very severe life-threatening occurrence. It's characterized by one or more of the following changes in the baby: color changes, apnea, muscle tone decrease, choking, gagging, or an altered level of response in the infant that's a year old or younger. Okay, some nursing procedures that we want to touch on that are unique to newborn. Just remember that children are not just little adults, okay? Pediatric dosing for medication purposes has to be precise to ensure adequate therapeutic levels and that there is not toxicity that's occurring. Dosing for meds and peds is always going to be weight-based. Because we know that infants are at greater risk of toxic levels. They have immature kidney function for excretion. They have smaller amounts of pancreatic enzymes. And so they are more likely to suffer from things being outside of a therapeutic range or level if we're not careful. In SIM, one of the things that we're going to be talking about in depth is review of the administration of injections or medications, both subcutaneous and intramuscular. So that's not going to be on our test for this unit, because we're going to have that in sim throughout the semester, and it'll be on your final exam at the end of the semester. When you're giving patients or babies liquid medications, it's important to use the side of the mouth or the inside of the cheek towards the back of the mouth so that they can't, force it out. You're trying to get them to swallow it. Sometimes ways you want to help coax them to swallow would be stroking underneath the neck. You could pinch the cheeks. That's going to make it so that they have a harder time to expel the medication. You may want to use the patient's pacifier as a helpful technique. You put a little bit of the medication in, you give them the pacifier to suck. You put a little bit of medication in, you give them the pacifier to suck. You can even use the nipple from a bottle. Take the nipple off the bottle, you put that in the baby's mouth, you insert the liquid into the nipple, and then the patient sucks on it through that nipple. What you never want to do is add the medication to the bottle itself. And the reason for that is you don't know that the baby's going to end up taking all of that bottle. And if they don't, then we don't know how much of the medication they actually received. If a baby does receive medication and in doing so then spits it out or throws up, you never want to re-administer that medication for that same reason. You don't know how much of it they absorbed and swallowed, and you don't want to repeat it and then risk exceeding therapeutic ranges and end up with toxic levels of that medication. Discipline. How do we discipline a newborn or an infant? Well, that's challenging. Your book says it's impossible to spoil an infant. And frankly, a lot of the discipline techniques that we would tend to lean towards are just probably not going to be effective in the very young baby and could actually end up becoming harmful if we're not careful. The things you could focus on are limits, setting limits that are intended to ensure the baby's safety. Use distraction as much as you can to avoid danger. If a child's heading in the direction of the electrical outlet that they might try to stick their fingers in, to just say no repeatedly or to start slapping their hand may or may not accomplish what you want. But if you can get their attention on something else, they'll forget all about that electrical outlet they were pining for. Temper tantrums are an infant's way of communicating their emotions. They're going to cause, frustration in the parent, but they are a direct result of frustration in the child. Sometimes it's because they're hungry, sometimes they're sleepy, sometimes they're angry, sometimes they're sick. So helping to try to control some of those factors may decrease temper tantrums, but ultimately the child does not know how to express themselves any other way, and that's why they do what they do. When possible, you can ignore tantrums. Sometimes ignoring them helps to not give them, positive reinforcement, and they may do it less. Another thing would be to reward the good behavior. When you see the good behavior taking place, which again, I'm talking about infants, that's kind of hard to recognize, but rewarding the good behavior usually works out better than trying to punish the bad behavior. Corporal punishment, which would be like spanking and hitting the child, those have been associated with negative consequences. They can cause harm to the child. They can affect the child's neural development. They see, sometimes these figures, these parents or caregivers, as a threat and to their environment, and that can obviously result in some less than desirable responses. In general, it's less effective. It's associated with higher incidences of aggressive behavior in the child. The children who've been punished in that capacity most of their life tend to be ones that grow up to abuse substances, have higher crime or violence rates, and of course it risks injury to the child. So we want to try to avoid it. Some great ways to also provide, limits to their settings, or try to encourage good behavior, is consistency and routine. The more consistent you are and the more routine and structure you provide, generally children respond well to that. If you don't have any sense of structure or routine or schedule to their day, then you're less likely to see those behaviors addressed. Okay, colic. So colic is basically unexplained fussiness from a child that is reoccurring. They tend to have this behavior, this frequent crying, not consolable at the same time every day. There has been some, possible links to gas, air from swallowing, probably from feedings, that sometimes by burping them frequently, we can reduce that. But by definition, colic it's unexplained fussiness and crying. So it's different from, a baby that's suffering from gas and needs gas drops. Providing stimulation can sometimes help. Things like going on a car ride, massaging the baby, putting them in an infant carrier where you're like wearing them so then they can smell and feel mom. White noise, which I only recently learned there's other color noises too. There's brown noise and gray noise and pink noise. So anyway, some of these forms of noise can also be stimulation that helps sometimes improve the colic tendencies. Using a pacifier may help. Giving them gas drops like simethicone drops, but ultimately it just has to resolve on its own. If it's true colic, it's just going to disappear with time. Usually when the baby's about 3 to 4 months of age, it'll go away. We want to foster or promote positive parenting skills. We want to encourage the caregivers to talk to the baby, respond to the baby's sounds. This is part of that developing the trust element of this phase of life. Read to the child, sing or play music for the child, praise and give, positive attention. Cuddle and hold. We identified that touch was very important, and play often with the child. We also want to encourage caregivers to establish a medical home. That's, usually going to be the pediatrician's office, but we want there to be someone consistent who's going to be taking care of and monitoring the child over time. So this should be your primary care provider that's going to see the child comprehensively. Like every time they get to be another month older or another couple months older, they're coming back seeing the same doctor. When we take the temperature of the baby, there's different ways we can do that. The most common and preferred are to use a digital thermometer that's taken either tympanic, which means in the ear, or temporal, which means across the forehead and sometimes touching behind the ear. We don't see rectals used for anything other than, need for very accurate readings, and it's usually done by professionals, so it's not something we want to encourage the caregiver to do for the child. Axillary can be used beginning at 3 months and moving upward, but it's also sometimes a more finicky choice because it does take a little bit longer for the reading to collect, and the child has to be relatively cooperative for that to work. You won't see us using an oral temp on, babies very often because it's hard to ensure you're getting underneath the tongue when you're taking that temperature. What are some indications of illness in a newborn and infant? There's a whole list in your book on page 160, but some of the ones I want to bring specific attention to are a change in the baby's temperature to greater than 99.3 if it's taken axillary, or 100.3 if it's taken rectally, which, remember, a rectal temperature is going to be a degree higher. A baby that's vomiting, that has less than 6 wet diapers in a day. A baby with fontanelle changes, whether that be sunken or bulging. If there's no appetite, if they start having a foul odor or blood that's coming from the cord or from a recent circumcision. If their level of consciousness changes, it becomes decreased, or they're lethargic. If they have, increased irritability and they can't be consoled. If they experience the blueness of their hands and feet outside of that first 48 hours of life. If they're getting rashes, if they're having drooling that's not associated with teeth erupting, if they don't want to lie down, could be a concern, especially in the children that are 8 months and older. Other red flags would be not wanting to lift their head or not having head control, not responding to loud noises, if they are extremely floppy, which means like muscle tone is atrophied, if they lack a response to visual or auditory cues, if they can't focus on their caregivers' movements, if they have poor weight gain, if they're not trying to crawl by the time they're a year. Those are just some of the things that would be concerning. And those are also listed for you on page 160 as well. Okay, and referencing the hospitalized infant and newborn, the main thing I want to bring attention to is that when a baby is hospitalized or experiencing chronic care needs, we tend to see some delays in their development because they're not in their normal setting. We still want to put emphasis on play, even if they're in an alternate environment. We want to make sure that, we're taking the approach of least invasive and least painful procedures come first. Procedures for babies and children in general should not be performed in the child's own hospital room. If it can be avoided, it's better if it's in like a treatment room, because then the child doesn't begin to fear their own hospital room. If they know that that room is safe, that gives them a place where they can be calm and relax and feel comforted, then that's what's ideal for them. Anything painful to an adult is going to also be painful to a child. So pain management is important, and how a baby or an infant responds to pain is also important. So we need to know that pain is going to affect the baby's vital signs. It'll cause things like their heart rate to go up, their respiratory rate to be elevated, their blood pressure is going to be increased, their oxygen saturation is probably going to decline. It may result in changes in their fluid and electrolyte balance, such that they experience losses. Sometimes pain is affecting the immune system, causing it to be depressed. So pain relief should be a goal, even in the infant newborn phase. Pain relief can be IV or oral, depending on what's going on. We need to definitely monitor the patient closely if they're receiving opioids, making sure that their respiratory rate and their pulse ox are staying in appropriate ranges. Sometimes they'll use things like Imola cream, which is an anesthetic cream that's used for things like starting an IV, but it does require a doctor's order. It is only beneficial if it is applied an hour to an hour and a half before the procedure, so that it has time to actually numb the area intended. When identifying or rating the pain for a child, there are different scales that can be used depending on the child's age and cognitive abilities. For newborns and infants, it's going to be the FLAC scale, which FLAC stands for faces, legs, activity, crying, and consolability. There's actually a table about it in your book on page 163. that talks about, how you score the FLAC scale. And there are other non-pharmacological pain prevention methods that can be used, so those can be explored as well. Some of the complementary or alternative therapies include infant massage and music therapy. Music therapy has many benefits, for the baby in helping to console them and increase their communication abilities and help them to concentrate and develop that as well. We know that, all of these therapies can also be beneficial in improving sleep patterns, improving their bonding and attachment with caregivers, and that's going to also improve their growth. Okay, chronic care for the infant and newborn. Premature infants, that's specifically those 37 weekers and younger that we're talking about. They're going to tend to have more caretakers. They may require a multidisciplinary team of a variety of specialists to care for them. We also would expect that they would require frequent developmental and neuro exams to determine how they're progressing and make sure that they are improving and acquiring these milestones and not the other way around. GBS or group beta strep is something that can occur abruptly. It happens as a result, it arises from colonization of group beta strep in pregnant women, and this infection can actually be passed to the baby through the vagina, the bacteria that occurs in the uterus, and so that's why all moms are tested for GBS before their delivery, and any mom that tests positive is going to receive penicillin treatment prior to their delivery. These cultures are usually done at 35 to 37 weeks gestation, and whoops, we went the wrong direction. Okay, we can't go backwards, so hopefully that was it for that slide. Anticipatory guidance, that's just things you can anticipate. One is ways in which we want to prevent injury in this age group. So we've already said some of them, things like choking hazards, safe to sleep positioning. We want to make sure that they're getting their immunizations as scheduled, because we know that they have immature immune systems. They lack the antibodies they need for protective purposes, and these vaccines can protect them from some very serious diseases. We want to ensure good hand hygiene, both on our part as the provider or the healthcare provider, but also encouraging that for the caretakers for the child. Their environment should be smoke-free. We want to educate on the importance of smoke and carbon monoxide detectors. All firearms, weapons should be locked away. If products are recalled, we want to make sure that there's ways for families to find out about that information and go through the necessary checks to see if their items are affected. There should be a place where emergency phone numbers are easily accessed. Things like the doctor that the child sees, maybe the nearest hospital, who you'd call for poison control, for a fire, for the police. That information, when they need it in an emergent setting, it's easier if it's someplace easy to locate. Because we know that just on average, accidents and injuries are the leading cause of death in children younger than 19 years. With pets, you never want to leave the baby alone with pets, especially cats. Cats are known to have that desire to suffocate the infant, and I don't know that they actually are malicious in that way, but they will, like basically ball up and lay on the child, and sometimes that's happening on the baby's face. You want to watch for, the potential to aggravate the pet, and the pet might bite the child, so they never need to be left alone. With water, also never leave alone, even for a moment. any amount of water is scary and could be dangerous for the child. You want to remove any water collections immediately after you use them. This could be like the bathtub being filled up. It could be like the mop bucket being filled up. A kiddie pool outside, because any collection of water is dangerous for an infant. Make sure the lids to toilets get closed so that they don't have any access to that. And when the child's old enough, it's great to encourage these learn to swim programs that give the infant exposure to pool time. It's on an increasing basis over time, and it helps them to learn how to safely stay afloat if they ended up in water. These programs do suggest limiting. That's what the limitation of time was. So these learn to swim programs, they limit infants' pool time to a 30-minute window because of the belief that prolonged submersion in water increases risk for water intoxication and exposure to E. coli. So learn to swim programs are programs that actually teach the baby how to stay afloat if they were to fall into water, but they're going to be short because of the dangers of prolonged water exposure. Burns, we want to make sure that we're not holding the child when we're dealing with or around hot surfaces or substances. We talked about microwaves already, not microwaving their food or milk. Minimizing direct sunlight, making sure that they're wearing sunblock or a hat for protection from the natural rays. If we've got pots on the stove, turn the handles away from the outside of the stove so that they can't accidentally be reached up and grabbed and pulled down and cause a burn. Checking the water temperature of the tub, never leaving the child in the bathtub even without water. It can be dangerous to have the tub be empty and the baby placed in there, because before you know it, they might figure out how to turn the faucet on, and they might turn it on to scalding hot, or just turn it on in general, and then it's a drowning hazard. Always check the water's temperature before you place the child in it. It's a better idea to draw the water and then put the baby in the water versus doing it, simultaneously. Water heaters should be set to less than 120. Electrical cords should be kept out of reach. You should put the protection plugs and outlets so that they can't stick their fingers in it. And babies should sleep in flame retardant sleepwear. In terms of choking, make sure to keep all choking hazards, small objects out of reach. Make sure that you cut up food into bite-sized pieces. Foods that, can be very dangerous and may need to be avoided in the first couple of years are things like hot dogs, grapes, raw carrots, peanuts, popcorn, chips, even the tiniest chip. Because of its sharp edges, it can get lodged in the throat in just the right way that they can't easily pass it or get it back up. Candy, marshmallows, because of their ability to expand, peanut butter for the same reason and its stickiness, and pretzels. If you are going to give, some of these kinds of foods like hot dogs and grapes, they got to be cut up into tiny, tiny, tiny pieces. The airway is smaller than an adult pinky finger. So if you think about what gets the respiratory content, we'll look at this a little bit closer. But if you think about the newborn's airway is the size of an adult's pinky. I mean, I've got some pretty tiny hands, but that's a pretty small airway. And so, it doesn't take much for it to choke the child. Think of things that are small enough to fit through a toilet paper roll. If it can fit through that, it could be choked on, or it could be a hazard to the child, especially the child that's getting older. For poisoning, poison control, the number is 1-800-222-1222, and that's one of the things that was advised, is that be posted somewhere in the home. And anything can be a poison: medications, cleaning solutions, alcohol, plants, any household chemicals, all of that needs to be kept out of reach because of its danger to the baby. In terms of falls and injury prevention, we never want to leave the child alone on a surface. We want to make sure that we're using gates for stairwells. They actually discourage the use of walkers, the toys that babies can be placed in and then they can move and navigate themselves because of their ability to possibly go off of a surface and fall. Any heavy furniture should be secured, especially when the child's of age to start pulling up on things, because they're not going to know whether something is stable enough when they go to pull up on it. They're just going to grab. And so it can be very dangerous for them. And then, educate on proper hand placement for holding a child, like holding a child in a way in which their, bottom is supported well, their head is supported well. And when they start to get to that age where they want to throw themselves backwards, then we also want to have a hand supporting their back, protecting their head and neck. Always use the proper car seats. When traveling in the car, even in an airplane, infants should be in the back seat facing backward, so rear facing. Children should never be left unattended in a vehicle, and we need to make sure that we're aware of the state-specific laws for car seats to make sure that we're abiding by them. They change frequently, so it's a good idea to know where you can find those updates. There's such thing as a car seat challenge test. That's one of the things that a baby has to pass before they can be discharged from the hospital. So they have to be able to tolerate a certain length of time in a car seat and not experience apneic episodes or bradycardia or desaturations. So that's one thing that you may hear talked about in the clinical settings this semester. Electrocution, that's why we want to make sure that cords stay unplugged because they're a hazard to a baby. They can also chew on things and that can result in electrocution. So making sure that we're keeping an eye out for something that might be chewed on, that would be an indication like, hey, I need to put this in a different location or make sure this stays unplugged. Suffocation from excess bedding, toys in the bed, even some, crib safety rails can actually be dangerous. Make sure that we don't have bags like plastic grocery bags within reach of the child. And when you're using a sling or an infant carrier, make sure that you're using it properly to determine if the child's okay and able to breathe adequately. Child abuse. Child abuse is actually going to come up in other chapters later. The main thing to touch on right now is that anything that you're suspicious is a form of child abuse, you are required to, or you're supposed to, as a mandated reporter, report that. Your report may not be directly to CPS. Your report may be to your higher-ups, so a charge nurse or a house supervisor or a nursing manager. But taking the necessary action to report that and determine if there's cause for more investigation and reporting to the official authorities. Neglect is an example of child abuse. So it doesn't have to just be abuse in the form of physical, hitting of the child. If the child's neglected, that's abuse. And failure to meet that child's basic needs, which might mean giving them their medications, bringing them to doctor's appointments when they have medical conditions, feeding them, caring for them, like changing their diaper. Any of those things can be a form of neglect if they're not taken care of. And your responsibility is to advocate and protect and care for the child in that regard. And then lastly, shaken baby syndrome. That is a term for abusive head trauma. It's something where, a person usually loses control. They're overwhelmed and beyond agitated, and they may use too much vigorous shaking of the child that can lead to traumatic injury. And so, we definitely don't want to, do that ourselves, and we want to make sure that parents are aware of that possibility. Most victims that succumb to shaken baby syndrome are younger than a year. Contrecoup is the term for injuries that occur on the opposite side of the head. So it's because they've been shaken so much that the pressure exerted actually did damage to the other side of the head. Statistically, young fathers are at the greatest risk. That's just from the literature. And so we want to make sure that we're giving resources and support systems to these young parents as well. Abduction prevention. One way in which you can help to reduce abduction tendencies is not posting information on social media, not putting birth announcements in the newspaper, not, placing the infant in the car seat and locking the car and then you go load your groceries. But really, just being aware of your surroundings and encouraging caregivers to be intentionally aware of their surroundings. And anytime they have any reason to be concerned or suspicious, call the police. It's never wrong to be safe. You'd rather that than the alternative. And that is it. So that is your content for Chapter 8 on newborn and infants. It did go a little beyond 75 minutes, but we tried to keep it as close to it as possible. As you're going back through it, if you need to a second time, or if you've listened and you have questions, write them down, email them to me. You can put them in the Moodle course under the course and clinical questions discussion forums so that they can be seen by everybody and I can answer them for everybody. But basically, if you have questions, definitely want to address that. You can also go to your book. The textbook is a great, resource to pair with this PowerPoint and Voiceover lecture to give you some clear information of some of the concepts that we talked about in this content. So that is it.